Although we may not think of diabetes as a disorder commonly managed by chiropractors, we can't escape the fact that many of our patients are diabetic, and we must be sensitive to the fact that about half of them don't know they are. Because neuropathy is common in diabetics, our patients complain of numbness and tingling in the extremities needs to be considered potentially related to diabetes and differentiated from that caused by nerve root, spinal cord, or peripheral nerve processes. Because diabetic patients also have associated problems with hypertension, hyperlipidemia, and obesity, we're well positioned to serve as not only screeners for these associated disorders, but a source of potential first-line intervention to support lifestyle changes which are proven to be successful non-drug options. For those who don't know they're diabetic, we'll see that we can use historical clues to raise our level of suspicion and then confirm with exam and lab testing. So how bad is the problem? The numbers are alarming and embarrassing given that 90 to 95% of diabetes is type 2 diabetes, which is largely preventable and curable with adopting a healthy lifestyle. In the U.S., the prevalence is around 13 to 14%, with a lifetime risk for high-risk populations as high as 50%. A study conducted in 2003 and published in JAMA estimated the lifetime risk for the general population based on being born in the year 2000. It was staggering at 33% for males and a worse prediction for females at 39%. Again, about half of diabetics don't know they are. Let's deal with just the U.S. For those older than 65, 10.9 million are diabetic. That's about 27% of them. Unbelievably, 1.9 million individuals over the age of 20 were newly diagnosed with diabetes in 2010. Diabetes is the 7th leading cause of death in the U.S. Your risk of death is twice that of individuals your age without diabetes if you're diabetic. Diabetes appears complex in that it results in so many complications, yet almost all of these complications can be eliminated in type 2 diabetics by eliminating diabetes. 75% of diabetic-related deaths are due to macrovascular or large vessel involvement through accelerated development of atherosclerosis, and this is less affected by medication management compared to microvascular issues. 66% of diabetics are hypertensive. Diabetes is the leading cause of blindness in the U.S. It is also the leading cause of end-stage renal disease, gangrene of the feet, and the leading non-traumatic cause of the need for lower limb amputation. Smoking increases that risk. Diabetes is the leading cause of neuropathy, with about 80% of type 2 diabetics affected. Polyneuropathy is found in about 20% of type 2 diabetics. All of these diabetic complications and sequelae lead to an estimated cost of $174 billion annually. So, is it possible to piece together enough information from the history to detect someone who doesn't know they're diabetic? Well, we'll first talk about risk factors and try to assemble a profile of someone at high risk. Clinicians are generally aware of some of the common clues, including family history, older age, being hypertensive, and a smoker. But more recently, listed as one of the strongest predictors is physical inactivity. Other less common clues for females are polycystic ovary disease, delivering a baby greater than 9 pounds, or having gestational diabetes. But what is the single most significant risk factor? Obesity. The relative risk for diabetes is dramatic when your BMI is higher than 35. The relative risk is 95 for females and 42 for males. The strongest clues are from a review of symptoms and complaints. So, what are they for type 2 diabetes? Well, that's easy. You remember the polys: polyuria, polydipsia, and polyphagia. Well, not so fast. These are the top problems for type 1 diabetics. For type 2 diabetics, understand that many individuals are initially asymptomatic, and when symptoms do appear, they are far more often complaints of fatigue, numbness and tingling in the distal extremities, and blurriness in vision throughout the day. These are often reported as the top 3. Eventually, when diabetes progresses, the polys may appear. Other clues are the patient feeling faint upon standing, feeling like they're going to pass out. This is something that happens to everyone on occasion, but it is frequent in diabetics. Diabetes blunts the usual sympathetic reflex of vasoconstriction in the abdominal or splanchnic veins in response to rising, causing orthostatic hypotension. We'll talk about this later under the exam. Additionally, frequent yeast infections are common in female diabetics, frequent infections in all diabetics, and poor or slowly healing skin lesions. For males, impotence is a fairly common consequence. So to recap, a patient who is the typical high-risk vascular patient with hypertension, hyperlipidemia, overweight, and a smoker is a good starting profile. More specifically, abdominal obesity, the pear-shaped individual with high levels of cholesterol, LDLs, and low levels of HDLs, is likely describing someone with the consequences of insulin resistance. Insulin resistance has many AKAs, first called Syndrome X, then the metabolic syndrome, and more recently called the cardiometabolic risk by the American Diabetes Association. Many consider this state, whichever term is used, as representing pre-diabetes and indicates the most opportune time for lifestyle modification as an intervention. Before we move on to lab testing, let's quickly review some key exam clues and focus for diabetics. Check for hypertension, determine the patient's BMI, and test for vibration loss in the distal extremities. And if you have a panoptic ophthalmoscope, check for retinopathy, including hard and soft exudates, and signs of hypertension, including silver wire, copper wire, arterioles, and AV nicking. How do you test for neuropathy? Let's use the recommended approach of screening with a highly sensitive test and confirming with a highly specific test. Likely for diabetic neuropathy, the use of a tuning fork can accomplish both. By applying a 128 Hz tuning fork to the bony prominence of the first toe, proximal to the nail bed, 2 tests are performed. The timed vibration test compares when the patient no longer feels that vibration to when the examiner no longer feels the vibration felt through the thumb in contact with the tuning fork. An abnormal test result has a sensitivity of 80 and a negative likelihood ratio of 0.35. In the on-off vibration evaluation, the test is performed twice on each foot. The total points possible are 8. The patient has to correctly indicate when the vibration begins and ends, 1 point for each. An abnormal test, which is 3 or less correct answers, has a specificity of 99 and a likelihood ratio of 26.6. Taken together, this means that if there is an abnormal time vibration test and an abnormal on-off vibration test, the patient is likely having a diabetic neuropathy. A general sensory screen should also be performed, and another option would be a monofilament examination, but that requires special equipment. For known diabetics, we'll use a different test, but for screening, chiropractors will generally order a fasting glucose. Glucose tolerance testing has some limits in ordering, with a requirement of MD ordering in some states. Options for screening do include, though, hemoglobin A1C or fasting glucose levels. Using fasting glucose, there are 2 categories. Prediabetes, or impaired fasting glucose, which has levels between 100 to 125 milligrams per deciliter. Diabetes is diagnosed at levels of 126 and above. Newer guidelines have also included hemoglobin A1C levels as a potential screen. It's a measure of glycosylation of RBCs. The threshold for diabetes is 6.5% or higher, and for prediabetes, 5.7 to 6.4%. The advantage of this test is it does not require fasting, and more importantly, it is a measure of sugar or glycemic control over a 3-month period, whereas fasting glucose levels can be manipulated over 24 to 72 hours, allowing some patients to, in essence, cheat by eating well, exercising prior to the test. This is especially important for known diabetics. There are other findings that indicate the degree and so indirectly the chronicity of someone's disease. Primarily in the urine, loss of glucose, albumin, and ketones is found. Certainly with loss of albumin, renal involvement is indicated. In the serum, associated hyperlipidemia, decreased albumin and abnormal albumin-creatinine ratio, and loss of potassium or low potassium are found. As a side note on potassium, in a previous presentation on hypertension, it was discussed that low potassium has been identified as contributing to hypertension, but low potassium also increases the chance for diabetes. A recent study in the American Journal of Clinical Nutrition indicates low potassium may contribute as much as 18% of the increased risk seen in African Americans. Insulin, which has mainly a hypoglycemic function, interacts with hormones that are referred to as counter-regulatory. These counter-regulatory hormones include glucagon, epinephrine, norepinephrine, the catecholamines, cortisol, and growth hormone. Insulin acts to promote cellular intake of glucose, inhibiting the breakdown of glycogen and inhibiting the production of other sources of energy, such as from free fatty acids. The counter-regulatory hormones generally act to stimulate glycogenolysis and gluconeogenesis. Catecholamines, in particular, suppress insulin secretion and stimulate hepatic glucose production. The hypoglycemic function of insulin is the result of several mechanisms, including promoting the uptake of glucose by mainly muscle and adipose tissue. Both chromium and potassium are needed for the proper functioning of insulin. At a cellular level, it's important to note that either insulin or exercise can activate a process where the glucose transporter GLUT4 found in the cell cytoplasm is prompted to embed in the cell membrane, facilitating glucose transport into the cell. Insulin is then affected by peroxisome proliferative activator receptors, or PARs, which activate genes that regulate insulin. Drugs can facilitate this process, like thiazolidines, which bind to PARs, reducing tumor necrosis factor alpha's inhibition of GLUT4 and promoting fat synthesis. Remember, though, that not all cells require insulin to take in glucose. These cells are the most vulnerable during hyperglycemic states, and yet another process complicates this effect. For cells containing the enzyme aldose reductase, glucose is reduced to sorbitol. If that cell does not also possess sorbitol dehydrogenase to oxidize sorbitol to fructose, the sorbitol is trapped in the cell. So here are the cells that don't require insulin. They are prime targets for the toxic effects of hyperglycemia. Now here are the cells that have aldose reductase that can convert glucose to sorbitol. Now look at the cells that don't have the enzyme to convert sorbitol to fructose. Now you see the two-stage process of damage, where the cells take in glucose without the need of insulin, and in hyperglycemic states, this is simply too much. Then the glucose is converted to sorbitol, but can't get out, leading to toxic effects and also resulting in an osmotic magnet effect, drawing fluid into the cells. When this is the lens and retina, vision is affected in the short term due to fluid retention and in the long term due to damage. We can see the same problem with Schwann cells in the nervous system, the kidneys, and RBCs. In fact, this glycosylation of RBCs is what forms the basis for the HA1C test. Diabetes affects all cells, but the damage on a large scale is due to neurovascular involvement. The vascular system is affected through two processes based on the size of the vessel. Macrovascular involvement is due to accelerated development of atherosclerosis. Microvascular or small vessel involvement, however, is due to damage to the intima, leading to hyperproliferation. Ironically, this hyperproliferation blocks the blood vessel. The three apathies related to this microvascular damage are for the eye, retinopathy, for the kidney, nephropathy, and for nerves, neuropathy. So in addition to the damage directly to the cells of these systems through the previous processes described, they lose their blood supply through blockage of the small vessel supply routes. For nerves, for example, the vasa nervorum are blocked, depriving nerves, in particular sensory nerves, of their blood supply. Ironically, a reaction in the retina to microvascular blockage is hyperproliferation of new vessels, which is damaging and a cause of blindness. The literature is clear that tight control of sugar levels, called tight glycemic control, reduces the risk for microvascular changes and subsequent damage. Chiropractors need to be acutely aware of the neuropathies associated with diabetes. Let's explore how they are presenting. The classic is the bilateral distal involvement, most common among the neuropathies. However, there are other, less common but important neuropathies which we need to be on the lookout for. Because diabetes is not exclusive to any one area of the nervous system, neuropathies also can involve cranial nerves, peripheral nerves, and the autonomic nervous system. Cranial nerves are more often affected unilaterally, in particular those that control extraocular eye movement. This actually is a neurovascular event that results in double vision or diplopia. Large single peripheral nerves may be affected, leading to what is called amyotrophy. These include the median nerve and femoral nerve, among others. The presentation is alarming, with severe pain and significant muscle atrophy. This may resolve over about a 1-year period, or in some cases persist. Finally, the autonomic nervous system is involved. For the sympathetic nervous system, the most common result is orthostatic hypotension. Checking the patient's blood pressure lying and then standing after 2 to 3 minutes, it's possible to discover if the patient has orthostatic hypotension. If the systolic blood pressure falls 20 to 25 points after 2 to 3 minutes of standing, compared to the supine blood pressure, it's likely the patient has orthostatic hypotension. For the parasympathetic nervous system, cardiac and gastrointestinal symptoms develop. For example, diabetic diarrhea may result, as can constipation. In fact, any patient with what appears to be irritable bowel syndrome should be screened for diabetes. Cardiac involvement may include a slowed heart rate or arrhythmias. So let's review the big picture here. We need to be on the lookout for diabetes. We likely have many patients who are pre-diabetic or diabetic and don't know they are. By using some valuable historical and review of systems clues, we can raise our level of suspicion to the point of feeling the need to check physical exam and then lab findings. In addition to the typical cardiovascular high-risk profile of obesity, hypertension, and inactivity, we also look for some clusters such as numbness and tingling in the distal extremities, blurriness in vision off and on throughout the day, and most importantly, fatigue. Diabetes is one of the primary causes of a complaint of fatigue. Eventually, the polys may appear: polyuria, polyphagia, and polydipsia. The key exam clues were changes in the retina visible on the ophthalmoscopic exam, especially using a panoptic which magnifies the view 5 times. Hypertension, testing for orthostatic hypotension, calculating the BMI, and sensation loss, and most importantly vibration loss, measured with the on-off and timed test. Lab testing confirmation was with a fasting glucose of 100 to 125 milligrams per deciliter for prediabetes and 126 or greater for diabetes, or an abnormal hemoglobin A1C. The recommendation was to use also A1C as a measure of RBC glycosylation to gain a better sense of long-term glycemic status, which also has the advantage of not requiring a fasting glucose measure. In Part 2 of this presentation, we will review the management options for patients and how you as a clinician can make choices with the patient's input that fit your comfort level and practice environment while maintaining the patient-centered approach of dealing with their preventable and in many cases reversible disorder.